A common clinically encountered drug, metformin. Metformin and the important clinical information related to chronic disc kidney disease is the topic for discussion today. So before going into CKD, let us discuss regarding few important points regarding metformin. Metformin, important drug in the diabetes management, especially the type 2 diabetes. What is the mechanism? Three primary mechanism. It reduces the hepatic glucose release, decreases the absorption, and also increases the sensitivity of the insulin, to glucose. Three major mechanism. Dose starting with 500 milligram BD twice daily can be started. Depends on the patient HbA1c level. The maximum up to 2000 milligram or 2 gram up to 2.5 gram you can use in the patient as per the titration which is required. Is only metformin is enough to manage diabetes? Sometimes yes, sometimes no. A patient might require add-on therapy. What are the commonly encountered side effect of this drug? Since it is having some issue with the absorption, it can cause vitamin B12 deficiency in the long run. GI symptom is common, bloating, diarrhea, vomiting, gaseous distension is common. Third, the serious one, lactic acidosis. It increases the risk of lactic acidosis. Per se, this drug might not be directly nephrotoxic, but increases the risk of nephrotoxicity, or it also increases the risk of lactic acidosis. This is a short, brief summary regarding metformin. And one more point, is it safe in during pregnancy? Yes, during second and third trimester of pregnancy, it is safe. Coming to the clinical information which is related to CKD. First, what is the EGFR? EGFR, estimated glomerular filtration rate. If it is less than 30, better to avoid it. If less than 45, you can reduce the dose. But this info you might get in the any app itself. But what the info I want to add is, in AKI, better to avoid, because in AKI the creatinine varies daily, the EGFR varies daily. So till the time stabilization of the patient, don't add this drug. After stabilization of the AKI, you can reintroduce the drug for the management of diabetes. So don't strictly follow this EGFR in situation of AKI, which is not going to help. And in CKD also there will be a particular situation. Suppose if GFR is falling gradually, since this drug increases the risk of lactic acidosis, yes, you can consider some other drug. But suppose if this particular drug is having better control of diabetes, and if the patient is affording it compared to other drug, if the patient is not willing for insulin, considering the other parameters, if the patient is not having risk of CCF, yes, considering the EGFR even little bit, you can lower it down, taking into consideration other risk of lactic acidosis. This is second point. Third, whenever a patient is admitted in ICU, better to avoid this, because in ICU setup, of course, as per the guideline, you have to manage with insulin. Subsequently, once the patient comes to the ward, you can manage with metformin. At the time of discharge, you can reintroduce or introduce metformin as per the requirement. And fourth point, whenever CCF is there, CKD is there, even at a bit higher EGFR, let us take 35, let us take 40, then also there is a risk of lactic acidosis. So take the parameter or the clinical situation of a patient as a whole. How well hydrated he is, how well the sugar is under control, what are the cardiac status, is there any past history of MI, because this metformin having this side effect in CCF increases the risk of lactic acidosis, and in some situation even cardiologists avoid this drug. Fourth, whenever a patient is undergoing a contrast study, that is CT or MRI, better to stop the drug 5 days prior and make sure the patient is adequately hydrated. And after the contrast study, you can wait for 2 days to reintroduce the metformin. Is it absolute criteria? It is not absolute criteria. In the clinical field, you can't treat by looking at the Google, or by absolute answer you can't work. You have to get into other parameters: age, risk of AK, other nephrotoxic drug, other status like hydration, blood pressure control. All this you have to take into consideration. As a consensus, better to stop metformin and you can reintroduce to prevent the risk of contrast induced nephropathy. Okay, so this is one important point where we usually get references day in and out. And the last point which I have to add is this metformin EGFR. Many a times the CKD patient per se might be CKD stage 3B or 3A. Because of some acute deterioration, the EGFR might have fell down on the particular day of your assessment, but there is a chance it might come back to normal once the acute problem is treated. So wait for the EGFR to recover. Suppose if EGFR is stable at a particular value, let us take as 40, even at this stage patient comes in the CKD stage 3A or 3B, whatever it is. Suppose if the EGFR dropped and come back to normal, yes, you can reintroduce this particular drug metformin, because affordable patient, if they have tolerated it well and it improves their glycemic control, because in diabetic patient probably uncontrolled glycemia is the major problem which leads to all this. So always have a focus on the glycemic control. So that's all regarding this metformin. Suppose a student, again a question came, sir, metformin only for diabetes? No, nowadays there are conditions like metabolic syndrome, even PCOD, ADPCKD. These are the situation where they are using this drug in and out. So this kind of clinical info, at least to manage in what you might require. Bye bye, we will see in the other video.